is a great honor and indeed my pleasure to welcome you as our guest to this 15th annual Dr. Deborah Brathwaite Symposium on Cancer Awareness. This program is sponsored by the Barbados Cancer Association, USA, Inc., and in collaboration with the Barbados Nurses Association, the NAA, and the Caribbean American Medical and Scientific Association, CAMSA. We promise you a dynamic, enlightening, and thought-provoking symposium, and we promise that you will leave with more than you expected. I take this opportunity now to introduce the Reverend Canon Dr. Stephen Fields, who is a Barbadian and was ordained in 1981. He's currently the rector of Holy Trinity Church, Thornhill, in the Diocese of Toronto. He graduated from Cottington College and the University of the West Indies with a diploma in theological studies and a Bachelor of Arts with honors. In 1993, he was invited to be the associate priest at the Church of St. Michael and All Angels, Toronto, from July 1996 to July 2011. He served as the incumbent of the Church of St. Stephen's in Downsville. He was appointed incumbent of Holy Trinity Church, Thornhill, effective August 15th, 2011. His ministry is supported by his wife, Lucy, an educator, and their two sons, Mark and Luke. I present to you the Reverend Dr. Canon Stephen Fields, who will deliver the invocation. Thank you.
Thank you, Dr. Alleyne. Let us pray. Lord Christ, you call us to serve one another as you served us, to bear each other's burden. You remind us that the measure of our life is how we treat the least of those among us, by feeding the hungry, quenching the parched lips of the thirsty, welcoming the stranger, clothing the naked, caring for the sick, and visiting those in prison. We thank you for the Barbados Cancer Association USA, an organization dedicated to minimizing the impact of cancer on Barbados and Caribbean communities in the US, as they seek to promote prevention, early detection, and prompt treatment of cancer in these nations. Prosper their endeavors, strengthen their hands, inspire their wills, and embolden their steps, that they may continue this good work, that it may redound to the benefit of those whom they serve and to your glory. Be present with us now in this evening hour. Shower all who speak and all who hear with your blessing, and lead us always forward along the pathway that is paved by love and joy, and that leads to life and peace. Hear our prayer in your name. Amen.
I take this opportunity again to introduce to you the President of the Barbados Cancer Association, Ms. Heather Marsh. Ms. Heather Marsh really crafted the symposium even in these times of COVID. Normally we have the symposium physically for the last 14 years plus, and she thought it would be fitting, even with this crisis, to continue to bring the knowledge and insight to the greater community. I present to you Heather Marsh.
I am delighted to welcome you to the Dr. Deborah Brathwaite Annual Cancer Symposium. Let me say I am pleased that we have delegates from various parts of the US and also from Barbados, from Canada, and I understand there's someone also participating from Costa Rica. Many of you are joining us for the first time because we are here in a virtual setting, and many of you may not be familiar with Dr. Brathwaite and her work. So let me tell you briefly who she was. Dr. Deborah Brathwaite was a past president of Caribbean American Medical and Scientific Association, which we refer to as CAMSA, and she was a respected member of the Physical Medicine and Rehabilitation Department at Kingsbrook Jewish Medical Center in Brooklyn until her passing in 2013 at the height of her career. Dr. Brathwaite was instrumental in bringing our annual Cancer Symposium to Kingsbrook. And we are pleased to honor her and continue her legacy. We thank the Medical Center also for their ongoing support, because as Ed said earlier, you know, if it weren't for COVID, we would have been at Kingsbrook this afternoon. I also want to acknowledge Dr. Brathwaite's sister, Gail Brathwaite. She's online with us. And Gail has continued to be a major supporter of BACA, and we are very grateful for her support. This program is a collaboration of the Barbados Nurses Association of America, which is led by Dr. Cicely Wilkinson, and also CAMSA, of which Dr. Alleyne is the president. The theme for today's session is pediatric cancers. The planning committee, chaired by Dr. Alleyne, has developed a comprehensive program, and it is our hope that by the end of this session, you will have a better understanding of pediatric cancer. We are also privileged to have clinicians from the US and from Barbados participating this afternoon. I invite you to use the Q&A session to your advantage, and I wish you a productive session. Next, I would like to welcome the Consul General of Barbados at New York, Mr. mholder, to bring you greetings.
Good afternoon, everyone. It is a privilege to associate the Consulate General of Barbados at New York with this very important initiative by the Barbados American Cancer Association. I first want to congratulate the President, Heather Marsh, and all the associated bodies for proceeding with this seminar. We do know that we're in a strange year and COVID has taken over everything. But the fact is that illnesses such as cancer, diabetes, the whole gamut of diseases and illnesses still need addressing. And I think that the continuation of the Dr. Deborah Brathwaite Annual Symposium is a testimony to the seriousness of BACA, the Barbados Nurses Association of America, and CAMSA in continuing to educate persons about cancer and its treatment, and to work for its prevention. I also want to say I am thrilled to see, apart from the collaboration between the associations, the collaboration between American colleagues and Barbados. I do know that they're all women. I don't know if that is by chance or choice, but I have no doubt that that will not detract from the important information that we are about to listen to. But you must forgive me if I, in particular, welcome Dr. Browne-Farmer from Barbados. I think that it is very important, not only in terms of this particular initiative, but in all endeavors that we bridge the gap between our homeland Barbados and between Barbadians in America, but not only Barbadians, that we bridge the gap with anyone who is interested in what we're doing. That is the only way we can grow. That is the only way we can share information that can benefit all sides of the fence. I am sure that Dr. Farmer will have some insights that can be shared by the other doctors, Maxwell, Jacobs, and Singh. And they in turn will be able to share some knowledge with all of us and with her that she can also pass on to Barbados. Dr. Ed has promised us an engaging session, and I know from experience that anything that is put on by BACA and the associated associations is always at a very high level. And I'm sure that this will be no different. So on behalf of the Barbados Consulate General in New York, the Barbados government, I welcome all who are in attendance, and I look forward to a good session. I did indicate that because of pressing engagements, I might not be, I'll be in and out, but I am sure that this, as I said before, will add to the body of engagement between all participants and all associations. Thank you all, and thanks for the opportunity to be part of such a wonderful exercise.
Moderator for the symposium this evening is none other than Tracy Proverbs-Singh. Dr. Proverbs is an MD, is an attending physician and medical oncology at John Tupper Cancer Center in Hackensack University Medical Center in the Division of Gastrointestinal Medicine. Ladies and gentlemen, friends, I give to you Dr. Proverbs-Singh.
Thank everybody for joining in the discussion on pediatric malignancies. We have three wonderful speakers today to provide insight into the field from their unique perspective. We look forward to the background review of pediatric cancers and hopefully learn quite a bit. We're going to be seeing the unique challenges and barriers to care in Barbados, and as well as look at the all-important psychosocial aspect of care of the pediatric patients and their families. Please use the chat feature to ask questions as you think of them. I will be looking at them as we go and try to include them in the discussion later. So first up, we have the renowned Dr. Rochelle Maxwell, who is currently an instructor in clinical investigation at Rockefeller University in New York City. She was awarded and currently working under the KL2 Clinical Scholar Transitional Research Grant through the National Institutes of Health. She received her undergraduate degree in biochemistry and molecular biology at Brown University, and her medical degree was at Columbia University in New York. She did both her pediatric and oncology training at Montefiore Children's Hospital, and she's well published in the field, including papers on the management and sequelae of chemotherapy, transitional science, looking at the secondary effects of hemophagocytic lymphohistiocytosis in the pulmonary system, some very intense research. So please welcome Dr. Maxwell, who will be providing us a very thorough overview of pediatric cancers. Dr. Maxwell?
Hi. Good afternoon, everyone. I first of all would like to thank the organizers of this symposium for inviting me to speak. I do consider it quite an honor. I will say that I am going to turn my video off while I'm sharing my screen just to prevent any kind of technical difficulties, because I have had that come up in the past. So I will stop my video and share my screen now. Okay, so my task this afternoon is to provide you with an overview of pediatric cancer, and I've decided to frame it in terms of the challenges, the achievements, and the opportunities for advancement within our specific field. So this is really going to be a 10,000-foot view, and I'll be covering a lot of material relatively quickly. But as Dr. Proverbs-Singh mentioned, we will have time for Q&A closer to the end of the symposium, so do make note of any questions that you might have. I also want to put in a plug that September is Childhood Cancer Awareness Month, and so I do think that this is an opportune time for us to be having this conversation. So this is the outline of what we'll cover today. What does not have its own section up here, but will be interspersed throughout the talk, is a discussion of some of the disparities that we currently face in the treatment of pediatric cancer. And I think this is particularly important to mention because this is an internationally geared symposium. It's organized by those of us in the Caribbean diaspora. And I think it's always helpful to keep in mind the context in which some of the statistics that we'll talk about and some of the recommendations that we'll discuss, the context in which all of those are being made. So I'll start out with the epidemiology of pediatric cancer. So every year, about 300,000 children across the world, aged 0 to 19 years, are diagnosed with cancer. This breaks down to about 16,000 children in the United States alone, which means that every single day, 43 children are diagnosed with cancer. This also means that before their 20th birthday, about 1 in every 285 children in the United States will receive a diagnosis of cancer. The number of children undergoing therapy for treatment for cancer every year in the US is about 40,000 at any point in time, and the average age of diagnosis is about 6 years old. Pediatric cancer affects all ethnic groups, all genders, and all socioeconomic groups. There are some differences in terms of ethnicities where we notice that non-Hispanic white children actually tend to have higher rates of pediatric cancer, except for the acute leukemias where Hispanic children tend to have the highest rates. Despite all the numbers I just mentioned, the absolute risk of getting cancer in the pediatric age group is still quite low. And when you do the math, it's about 183 cases per million children in the United States. But even though the risk is low, the impact is still quite high because childhood cancer is actually the #1 cause of death due to disease in high-income countries, including the United States. It's actually responsible for more deaths than all the other causes of pediatric deaths due to disease combined. And when we think of this in terms of the ages of these children and the years of life lost, the impact really becomes very stark because you have the average age of diagnosis being 6 years. The average age of death due to pediatric cancer is somewhere between age 10 and 11. And if the average US life expectancy is around 78, 79 years, then what you're looking at is about 68 years of life lost for each child that dies from pediatric cancer. And that far outpaces the numbers for any kind of adult cancer at all. So this is clearly why our work continues to be important. So this map looks at the global incidence of pediatric cancer in various countries in the world. And what I want to draw your attention to is the fact that it is not equally distributed. So in the darker blue are going to be the countries that are having higher incidence of pediatric cancer, whereas the lighter blue have lower incidence of cancer. And one of the curious things about this map is that the incidence of pediatric cancer actually tends to be higher in higher income countries, which is quite opposite to what we think about with other types of diseases. And, you know, it's very interesting as to why that might be. And so the next map might provide us with a bit of insight into that, because this map is actually looking at whether or not in various countries there is the availability of a national cancer registry. And so the authors of this study were actually trying to track down the incidence, and the way they tried to do that was to go to these countries and say, you know, do you have records of how many children have cancer? And what they found is there's a very wide disparity between those countries that have, say, a national registry, such as the United States, as opposed to countries in, say, Africa, where there's really not a prevalence of having any kind of record keeping at all. And so what that translates to is the fact that at least some of the fact that there's a higher incidence in higher income countries is probably due to the fact that the record keeping is just better in those countries, and those deaths are being properly accounted for. What we know is that globally, about 40% of children with cancer will actually die before they receive a diagnosis. And we also know that the survival and the outcomes are very different in higher income countries as opposed to lower income countries, where the 5-year survival in the average high income country hovers around 80%, and in some low income countries can be less than 10%. So these are really sort of sobering facts, and I'm sure Dr. Browne-Farmer will address some of the barriers to care that may be experienced in different settings, and I think these are some of the things that we need to think about going forward to see how we can improve these numbers. So what is pediatric cancer? So it really is an umbrella term because it's a very heterogeneous and diverse group of tumors, and it's actually very distinct from the types of cancers that you tend to see in adult populations. So in terms of pediatric cancer, about 25% of what we would consider to be pediatric cancer actually falls under the umbrella of being a leukemia, which is a cancer of the blood system. And another quarter is basically some sort of a tumor in the brain or in the central nervous system. So that already takes care of the first half. The other half really is a very finely sliced pie with a variety of different diseases. And so if you look at the average percentages of all of these, they're each accounting for a very small percentage. So what this means is that there is no one type of treatment that will work for quote unquote pediatric cancer. It really depends on the type of tumor you have, the way the treatment approach will be, and we'll talk more about that later. The other thing that often comes up when people think about pediatric cancer is, where does it come from? Why does it happen? And to date, there have been no known environmental exposures or lifestyle factors that have been associated with pediatric cancer to any significant degree. And that's because usually these lifestyle factors, such as we think of smoking and lung cancer, usually these lifestyle factors, it takes decades for these impacts to really manifest into becoming cancer. So when you have a 2 or a 3-year-old that has developed cancer, they really haven't had enough time on this earth, quite frankly, to have any of those exposures really impact in causing their cancer. So essentially, the majority of pediatric cancers are what we call sporadic, which basically means they just happen. We don't know why. It's not inherited. It's quite simply just bad luck. So not only are there many, many types of pediatric cancer, but also the types of cancers that you would expect in one particular age group within pediatrics is very different from the types of cancers you would expect in another age group. So there are really 2 peaks that we tend to see. One is between infancy and age 4, which is right at the beginning on the left-hand side here. And then the other peak that we tend to see is in adolescence around ages 15 to 19. But what you will notice is that the types of tumors actually vary quite significantly across the spectrum. So when you're thinking about babies or young children, you tend to see a predominance of leukemias, a predominance of brain tumors and embryonal type tumors, which are tumors that basically resemble fetal tissue, versus when you look at the adolescent years, what you tend to see is a predominance of lymphomas and solid tumors, as well as bone and soft tissue tumors. And so it's really very different what the expectation is based on the age of the child, what the likely diagnosis would be. So how do these patients present? What are the types of symptoms that can show up that lead to a diagnosis of cancer? So there's a list of symptoms on the slide, and I'll just start with a caveat. Each of these in itself is not enough to establish a diagnosis of cancer. Even combinations of these are not enough to establish a diagnosis or even a likelihood of cancer, because quite frankly, children are quite the healthy population. And so the likelihood is that if a child has a fever, or a child is having headaches, or they have a lump or a bump somewhere, it's quite much more likely to be as a result of an infection or an injury or some other kind of illness than it is to be cancer. That being said, these are the kinds of symptoms that are sort of the entryway into medical care. So these are the kind of symptoms that you would then present to a pediatrician, who will then evaluate and do a more full workup. And if it's warranted, then refer you to a specialist like a pediatric oncologist. Once you get to oncology, we sort of, start from scratch and get the story all over again and do our own physical exam. We get a lot of information from lab work and imaging, but truly to have a definitive diagnosis of cancer, a biopsy needs to be done. And the reason for this is that really the only way to know what specific type of cancer you have and how you're going to treat it is to have that tissue diagnosis. This has become particularly important in the modern era because we're learning more about different molecular subtypes of tumors. We're learning about different kinds of markers that may be on tumor tissue. And these are things that may very well influence the kinds of therapy that we provide. And so without that tissue diagnosis, nobody is going to be willing to move forward with treatment because we don't know what we're treating. And until we do, it's not a particularly good idea, because as we'll talk about, these therapies can be quite toxic. And so these images are just examples of some of the things that we could see during the workup process. So this first image here is an X-ray of the knee, for example, and what you can clearly see is an abnormality right here in the bone of the distal femur, so the end of the thigh bone that's at the top of the knee. And there are characteristic features, let's say, of these images that we can look at and say, if I had to bet $1, I would bet that this is, for example, is osteosarcoma. But again, nobody's going to move forward with a therapy until somebody goes in there with a needle, gets a piece of that tissue, and is able to confirm that diagnosis. On the top right, this is an example of a brain MRI that's showing a tumor in the cerebellar area that would also need to be biopsied before moving forward. And on the bottom right is an example of what a bone marrow biopsy actually looks like for a child where we're suspicious of leukemia. We actually go and take some bone marrow cells, and this is something that you could look at and confirm that this is a type of leukemia. So what are the different treatment modalities that we tend to use? So they're quite varied. Surgery, chemotherapy, and radiation, I tend to think about in one bucket. And the reason for that is that most patients will have more than one treatment modality involved in their care. For example, if we think about that knee X-ray that could have been osteosarcoma, it's a very clearly defined tumor. We can perhaps, do either a limb-sparing surgery or an above-the-knee amputation, and that tumor mass itself will be gone. But what we've learned from treating children over the decades is that if that child doesn't also receive chemotherapy, they will 100% of the time relapse and succumb to their disease. And the reason for that is that before that mass has even formed enough for that child to experience symptoms or to have an abnormal X-ray, there are already small cancer cells that are sort of floating throughout the blood, so to speak. There's no way to detect them. You can't see them. But if you do not get rid of those cancer cells with chemotherapy, we know, unfortunately, what will happen. And so there's usually this multi-modality treatment that's involved, whether it's surgery and chemotherapy or radiation and chemotherapy, or sometimes all three if you are treating really difficult disease. Another type of therapy that you perhaps have heard of is bone marrow transplant. And this is sort of reserved for very aggressive disease and for particular types of disease. So for example, there are some aggressive acute myeloid leukemias that receive upfront bone marrow transplant, or there are some acute lymphoid leukemias that then relapse after chemotherapy, and the approach then is to do a bone marrow transplant. We think about transplant in two buckets, and they're allogeneic and autologous. And the difference really is, where do those bone marrow cells that we're transplanting come from? So in an allogeneic transplant, what that means is that you're going to go and you're going to look for a donor through the National Donor Match Program. You're going to find a match, and that is going to be the source of the donor cells that you're going to give to that patient with AML, for example. With an autologous transplant, what that is we're actually using the patient's own bone marrow cells. So sometimes this is done in the case of, say, you have a solid tumor, like a brain tumor that's really aggressive, and you really need to give very high doses of chemotherapy. When you give these high doses of chemotherapy, you know that you're giving so much therapy that your bone marrow is not going to be able to recover. So what you do is, in advance of giving that chemotherapy, you actually harvest the patient's own bone marrow cells. You put them in a freezer, you give them the chemo, and you know you're going to wipe out their own bone marrow. But then when you've wiped it out, you give their cells back to them. And that is able to engraft and make sure that they still have a functioning immune system. And then in the modern era, there's also many novel therapeutics that are being developed. There are various immunologic agents that are being developed. We are learning how to essentially use the patient's own immune system, how to engineer the patient's own cells to come in and fight their disease. And so this is a very exciting time in terms of therapies, because some of the things we're doing now, even when I started my training, did not exist. And so it's a good time because we're making and seeing significant amounts of progress. So when we think about treating a patient for cancer, everybody gets put on what's called a protocol. And that just basically means, this is your recipe, this is your cookbook going forward. These are the combination of drugs that you'll get at this particular time period, at this particular dose. And if X happens, we will do Y. And the reason this is important is to sort of ensure uniformity of treatment in some ways, and make sure that we are using to our best advantage all the knowledge that we've gained throughout the years of treating children with cancer. And it's to, in some ways, make sure that, you know, whether you're getting your therapy in rural Ohio or you're getting it in New York City, you're essentially getting what we think is the best standard of care to date, and that everybody's sort of following the same recipe. Chemotherapy is always with multiple agents. We never just treat with, well, I shouldn't say never. It's very rare that we treat with just one drug. And it's always administered in cycles. And what that does is it gives the bone marrow in the body a chance to recover after receiving these medicines, so that you're ready for the next round of medication. Most children with cancer will receive their chemotherapy through a special IV catheter that's placed in a very large vessel in the chest. There are some agents that can be taken by mouth. And the length of treatment really varies depending on the tumor type. Some courses can be as short as a few months, and then there's therapies, for example, for ALL that can be like 2 years long. So what are some of the challenges that we encounter with treatment? As I mentioned before, the absolute risk of pediatric cancer is really still quite low. So you're thinking 16,000 total in the US per year, but then remember that pie chart, there's a lot of different slices in there, right? And so we treat all these different slices very differently. And so if you think about one particular type of tumor and how many patients in let's just say the US are gonna have that specific type of tumor, it's a very small number. And so how do we then learn? How do we then test new therapies? How do we improve on our current best effort? And really the way we're able to do this is by doing multi-institutional and even multinational clinical trials. And the Children's Oncology Group is one of the main organizations that does this in the US. There's over 200 sites in the US. They usually have at least 50 clinical trials open at any time. And most children are treated at some COG member site. We really encourage clinical trial participation. It's the way that we've been able to make any progress over the last 40 years, and it's the way that we're going to continue to make progress going forward. So what are the outcomes like? So this gives you a brief overview of what you can expect in terms of 5-year survival in the current era from different types of pediatric cancer. So with all comers, your overall survival is going to be around 85%, 84, 85. And I will say that this far outpaces what can be seen with adult cancers. And kids just tend to do better with treatment overall. They're way more resilient. They recover way better. They tolerate way higher doses than adults can. And so even though the overall survival is in the 80%, you can see that there is still a big disparity between the different types. So there are some types of cancer where you're looking at a 98% cure rate, as opposed to other types where you're looking at a 65% cure rate. So this clearly shows us the areas in which, okay, we're doing pretty good, and also the areas in which, okay, we really need to work on getting those numbers better. And this is how we've done over the last 40 years or so. So if we follow this blue dashed line here, which is the leukemia line, you can see that in the 1970s, the cure rate for leukemia was hovering between 40 and 50%. And if we follow that up to today, we're closer to 90% for all comers. And again, that's really been the result of very coordinated efforts in terms of clinical trials, which is why we really emphasize the importance of enrolling in trials. So the last thing I want to talk about is pediatric cancer survivorship, because I think that this is a very important area. It's a very key interest of mine, clinically and research-wise. And this is because this is going to be the next thing, right? We are getting better and better at curing these kids. And so we're having more and more survivors. Right now, we have close to 400,000 survivors in the US, and we anticipate that that number is going to continue to grow exponentially as we get better in terms of therapy. But what we've learned, again, through studies, because we have this childhood cancer survivor study that's a multi-institutional study that really has been following a cohort of these patients since 1970, what we've learned is that even decades after therapy, so you could have had ALL at age 5, we cured you, you went on with your life, now you're grown, you have your family, and you're 45, but you're in heart failure because of the medications that we gave you when you were 5 years old. And so we're learning now more about the different toxicities that are associated with some of the therapies that we use. And it makes us a lot more cautious in how we administer these therapies, and also gives us guidance as to how we need to follow you after we've cured your cancer, to ensure that you stay healthy for the rest of your life. And so surveillance for late effects is really an important area. Again, the Children's Oncology Group has really led the field with this. They have very detailed guidelines about what we need to surveil at what time intervals based on what specific medications you've gotten. And this is something that's given to every person who finishes therapy as part of what's called a survivorship care plan. And so they have that moving forward when they're, away at college, and the person taking care of them there has no idea they have that information in their hands. So I just want to speak briefly about some of the major ones. So for example, psychosocial issues are huge, and that is with any kind of cancer therapy at all. And I'm sure Rebecca will address some of this more during her talk. Cognitive deficits is another huge one. And this this is actually an example of how we've really radically changed therapy based on what we've learned. Because, for example, in the 1980s, 1990s, we were treating every child with ALL with craniospinal radiation to prevent recurrence of ALL in the central nervous system. And what we found is that they lost a lot of IQ points when we did that. And it really didn't translate into them having a very good quality of life after we had cured their cancer. And so we found ways to basically eliminate that, to the point where nowadays, almost no one with ALL gets craniospinal radiation. We have found other ways to reduce the CNS risk without causing the kind of damage that we were seeing. Secondary cancers is also another one that I want to highlight. And that's because, you know, nobody wants to hear the words your child has cancer. And even worse than that, nobody wants to hear that twice. And so the ironic thing is some of the therapies that we use to treat the first cancer you had can lead to a higher risk of having a second cancer. And so these are things that we need to continuously monitor and watch out for. And then fertility is another area where I think we have a lot of room for improvement. Centers are starting to proactively now do things like egg preservation, sperm banking ahead of treating you with chemotherapy, so that for these patients who come in as adolescents, their fertility can be preserved post-treatment. So in wrapping up, I just want to say, you know, we have a lot of challenges within our field. Our numbers are small. You know, coordinated care is really only available at certain academic medical centers. So you're lucky if you live near a big city, whereas if you live, you know, in a rural town somewhere, you might not be so lucky. And that's unfortunate. The fact that we deal with young children and adolescents who can't consent for themselves makes for interesting conversations sometimes, and I'm sure Rebecca has a lot of experience dealing with some of that. And then because you're so young, when we treat you, you really have a lot of life left, and because of that, there's a really high risk of having long-term treatment-related effects. But despite this, we've made significant achievements. We've been able to bring our cure rates up, and this again is because of participation in clinical trials and really trying to rapidly adapt some of the novel therapies that have come out. Some of them have been tested in adult cancers, and we decided to sort of, you know, try them in our population. But I do think there are significant opportunities to get better. There's always a way to get better. And part of this is reducing disparities, not only within the US, but obviously globally, and reducing the toxicity of our therapies, and learning more about the individual patient's tumors so that we can harness that information. We can say, you know, your specific tumor may not need this high dose of chemo. We know we can cure you without giving you that much, so that you don't have to worry about, for example, heart failure down the road. So really putting together all the knowledge that we have to best serve our patients, because that's the whole point. And so with that, I want to say thank you and remind you that it is Childhood Cancer Awareness Month. And again, thank you for this opportunity. I really appreciate it.
Thank you so much, Dr. Maxwell. That was an excellent review. We got a good understanding of the extreme diversity of pediatric cancers, and not only diversity of diagnosis, but diversity of age at diagnosis and the types of cancers, as well as the treatment and the challenges. So I think everybody got a wonderful overview of what pediatric oncology is like. I think, you know, in a transition and related to a lot of the points that you brought up, we now have Dr. Chantelle Browne-Farmer coming to us from Barbados, who's currently at Queen Elizabeth Hospital in Barbados in the Department of Pediatric Oncology. She received both her bachelorette in medical and surgery and Doctor of Medicine at the University of the West Indies. Her clinical fellowship in hematology oncology was at the esteemed Hospital for Sick Children at the University of Toronto. She represents Barbados for the Sick Kids Caribbean Initiative, and she's been past president of the Junior Doctors Association of Barbados. Please all welcome Dr. Browne-Farmer as she speaks of the barriers of pediatric cancer, specifically in Barbados.
Thank you for that introduction, and it's my pleasure to be here with you today, invited by the Barbados American Cancer Association USA, who's obviously aiming to promote awareness of childhood cancer, which I think is very important. Just permit me, does anybody know how do I get to see my second screen? Normally it comes up so that I can see that, but I'm having a little bit of this issue here. Just one second. Okay, I think that's how we'll have to do it. Can everyone see the slides? Hello?
Yes.
Okay, thank you very much. All right, so I will be discussing the barriers to childhood cancer care in Barbados, as was said, and I hope to provide some insight into the structure of the health system supporting childhood cancer in the country, as well as a snapshot of the current epidemiology of childhood cancer here. I'll then move on to elucidating the barriers to delivery of care to these patients, and lastly, just a little bit of opinion regarding the next steps to improving care for these children. And so Dr. Maxwell nicely highlighted the global epidemiology for pediatric cancer, but I would just like to point out here that, as she noted, a lot of the data that's available is available from high-income countries, and many models have actually estimated that most children with cancer live in low to middle income countries. Upwards of 80% possibly of the global childhood cancer burden is in these countries, yet there is a significant survival gap between low to middle income countries and high income countries. And therefore, there is no surprise that the WHO launched its global initiative for childhood cancer 2 years ago now, aiming to increase prioritization of childhood cancer through awareness raising at global and national levels, as well as to expand the capacity of countries to deliver best practice in childhood cancer care. However, despite this initiative, political priority for childhood cancer care remains low in many of these countries, which is really regretful because, as Dr. Maxwell pointed out, most childhood cancers can be cured, especially when caught early. And this is in stark contrast to adult cancer, where, again, as she said, many adult cancers do not achieve such good outcomes. And if we really try to focus on doing better with childhood cancer in many of these countries, we would notice a great improvement. And so barriers to care are multidimensional, complex, and can be unique to each country. In Barbados, citizens generally have free access to healthcare and medicines in the public sector, usually without major fees, but with some exceptions. And this is obviously very different if you're being cared for in the private health system. We should point out that although Barbados is classified as a high-income country by gross national income per capita, it really experiences health challenges, health system challenges similar to those of many low to middle income countries. In Barbados, we have childhood cancer care centralized at a sole public tertiary care institution, the Queen Elizabeth Hospital. We have a pediatric ward that admits patients 15 years and under, so the children 16 and over have to be managed elsewhere, outside of the pediatric ward. We do have 2 dedicated rooms for pediatric cancer care. They're called isolation rooms, but they're really not. They're really more of the only bed spaces on the ward with doors, because there really is no, you know, air control and ventilation control really for those rooms. We have a PICU, which can hold about 3 patients. We have radiology services, which provide X-ray, CT scan, and ultrasound. We administer radiotherapy via a cobalt machine. We have a general lab and a pathology lab. And then we have personnel to support the care as well. We have 2 pediatric oncologists, myself included. Though we have other clinician obligations, I have general pediatric services, and my colleague, Dr. Alexis, she has obligations to the university. But we also have a supportive core of people, so general pediatricians and pediatric health staff on the ward. We have retained 2 oncology nurses, one in the outpatient clinic and one who's on the ward, and there's another one in training. We have general nursing staff on the ward, a pediatric intensivist, a pediatric cardiologist, and a pediatric general surgeon. There's 1 oncology pharmacist for the hospital with an assistant. And there are social workers and dietitians at the hospital, as well as adult subspecialists who we may frequently need to call on. So I noticed that one of the slides that Dr. Maxwell had up had indicated that we don't have a registry. Forgive the thunder in the background, sorry. But we do have a registry for childhood cancer since about, I want to say, more than 5 years back, and we've been able to input data from January 2012 up until now, and this was through the Sick Kids Caribbean Initiative, and I'll speak a little bit more about that later. So we saw 60 cases over this time period, which equal to about 7 cases per year, with an incidence rate of 11 per 100,000 children aged 0 to 18. The age range was 4 months to 18 years. The median age was 10.5 years, and male to female ratio was 1:1. Leukemias, not surprisingly, were the most common cancers, accounting for 32%. Lymphoma, osteosarcoma, CNS tumors, and Wilms accounted for 10% each. 13% of cases experienced relapse disease, 15% progressive disease, 8% either abandoned therapy or refused therapy altogether, and we had deaths accounting for 36% of cases, a mortality rate of 4 per 100,000 children aged 0 to 8. I was able to put together a quick survival curve for you of this data. I'm sure once the data is cleaned up, it may look slightly different, but I think this is the general gist. So we had 2-year survival of approximately 60% and 5-year survival of approximately 50%. And this is an improvement on previous decades. Data from my oncology colleague indicated that there was a 2-year survival back in 1985 to 1989 of 34%. So we have had some improvement over the years. When managing a child with cancer, the chain of care which we move through starts at the point of recognition of possible cancer through to referral for specialized opinion and care, diagnosis, both clinical and histological, and treatment delivery. As indicated, there's also the element of following up these patients long-term, but I don't have time to touch on that today. And then evaluation of system performance should occur at regular intervals. And so this pictorial demonstrates many of the key elements to each step, and we'll look closer now at the barriers to these. So the key elements of early recognition of possible cancer in a child come down really to parental education and health provider knowledge regarding awareness of childhood cancer and its signs and symptoms. And, you know, still in our society, many persons in the lay public do not even know that children can get cancer. And healthcare providers may unknowingly manage unresolving symptoms in children for some time without suspecting cancer. And so overall, you know, these elements really are limited by an absence of political attention and public campaigns of childhood cancer awareness, as well as limited provider knowledge of the signs and symptoms of childhood cancer. And these are things that really can be easily addressed. At the point of referral, the key elements here relate to the ability of the healthcare professional to really make early and appropriate referrals. In our experience, knowledge regarding the significant impact on survival that can be made by referring early sometimes is lacking and therefore does not drive decision making when it comes to dealing with these children. And frequently delays can occur when families are first referred to other specialties and there is no contact with the oncologist for any input. And so we frequently then get contact just only at the point of histological confirmation, which unfortunately in our setting in many cases is delayed due to various system failures. Socio-demographic barriers come into play here also because sometimes, unfortunately, families may resist referral for a variety of reasons, and some may lack support financially to even follow through with the referral process. So something that may seem simple, like transportation to hospital, etc., some families cannot keep up with, and so there are barriers to care there. Correct diagnosis is the foundation of cancer care, and there are several key elements required for this. Appropriate personnel, some of which are listed here. Professionals who have training and experience in the radiological diagnosis of pediatric malignancies is ideal, but failing this, radiologists who are connected to experts in the field for difficult cases would be probably the next recommendation. We unfortunately lack pediatric radiologists at our institution, and we rely heavily on adult radiologists who are occasionally limited in the expertise they're able to offer, no fault of theirs. We also lack a hematopathologist, very important since the majority of our cancer diagnoses are hematological malignancies like leukemia and lymphoma, and they rely on specialized testing like flow cytometry and molecular studies, which was alluded to in the previous presentation, for diagnosis as well as treatment evaluation and monitoring, and our lab capabilities are deficient in this area. Other deficiencies include the fact that MRI and bone scan are available but only off-site, and this obviously poses challenges to scheduling for these patients, transportation to these facilities, as well as costs, because sometimes the costs may need to be deferred to the families where our institution may not be able to cover that cost. We do not have PET-CT on the island, as well as MIBG, which is a type of scanning which can become very important for managing pediatric neuroblastoma, which is another very common childhood cancer. We, in terms of other personnel then with histologic diagnosis, we have a pediatric general surgeon, but no pediatric subspecialist surgeons, which can sometimes be a challenge. For example, with solid tumors like osteosarcomas, etc. Having a pathologist who has experience in the diagnosis of pediatric malignancies and who's connected to disease-specific pathology experts, just like with radiology, is of course ideal. We instead have to rely heavily on adult pathologists We do have one pathologist on staff who's had some additional pediatric training, but due to, I don't know, various institutional quirks, it seems that many of our samples are not flagged directly to that individual. And, you know, it's important to point out that the availability of advanced histological testing is important, since treatments of pediatric cancer are becoming very specifically tailored to cancer biology in so many ways that, you know, robust histological and molecular analysis, for example, are really crucial to selecting the appropriate treatment regimens. And we lack this specialized testing ability. To make up for some of our diagnostic deficiencies, dedicated financing for these would go a long way, but we lack this. Support for families at the time of diagnosis is also very important, something I think that the next speaker will go into. And so we do not have, unfortunately, dedicated psychosocial support specialists such as social workers, psychologists, child life specialists. We rely on the social workers who have their you know, agendas split throughout the hospital, but nobody specifically trained in dealing with oncology families. And so in general, barriers at diagnosis have major impacts on service delivery, where insufficient diagnostic capabilities can lead to treatment delay and abandonment of care. Moving on to treatment, the key elements here include trained personnel in various areas. This is not an exhaustive list here, but I will highlight the lack of palliative care physicians on staff at the Queen Elizabeth Hospital. This service is needed throughout a child's cancer journey, from start to finish, and not just when the opportunity for cure has passed. We also have challenges with drug procurement and access. I have them in red because it really is a major problem for us. Erratic supply of the essential medicines for oncology and supportive care drugs that the WHO has identified for children in cancer in Barbados is our reality. And while it should be noted that there are existing global market failures that impact the availability of some medicines, especially in small nations like ours, who really don't have much bargaining power, we have national and institutional specific challenges to maintaining a supply of these medications. So things like decentralized purchasing, weak procurement and supply management processes, which is largely non-data driven, and limited supplier incentive, just to name a few of the problems. I would point out here that our oncology pharmacy has been dislocated from the main hospital for some time, something that needs to be addressed. And we probably need enhanced capacity in oncology pharmacy staff, because we really struggle to get active participation from the oncology pharmacists in delivery of care to pediatric patients. They're not just there for, you know, mixing of chemotherapy, but they're important parts of the team. The clinical infrastructure, like radiation services and supportive care, are further key elements to treatment delivery. Our radiotherapy capabilities are limited by a lack of a linear accelerator, which can be crucial for treating certain pediatric cancers like lymphomas and solid tumors. You know, it really is essential to try to minimize side effects of radiation in pediatric patients who are still growing and who we anticipate to have survival into adulthood, as was noted before. And so we would want to decrease their chances of being impacted by a secondary malignancy later in life. And a linear accelerator does go some way when it comes to targeting just the areas requiring therapy and minimizing long-term effects. We unfortunately have erratic transfusion support as it relates to the supply of platelets. This has become even more of a challenge in recent times. And this really is essential to supporting children on chemo radiation therapy. Access to funding for therapies, again, often a major challenge. And so just like with diagnosis, insufficient therapeutic capabilities and socio-demographic barriers can significantly impact service delivery and lead to treatment delay and abandonment of care. And then lastly, evaluation of system performance, very important. You know, outcome monitoring is essential to improving cancer care and outcomes no matter where you are. And it's probably even more important in countries with limited resources, because quality improvement efforts there often mean the difference between life and death for many children. Reliable epidemiological and outcome evidence on which to adjudicate system performance cannot be considered simply academic or a luxury. You know, targeted allocating of dedicated personnel and infrastructure to this is essential for accurate and timely data entry, because we do have a situation where in order for our us to have our current data, we've had to identify one of the oncology nurses who's actively involved in delivering care to our patients as our kind of data manager in this regard. And healthcare resource workers in resource-constrained settings frequently lack the time to collect and review and analyze outcome information. And it's really important to have this because, you know, it really can dictate, say, a need for improved diagnostics in order to better affect outcomes, or it may point towards the need for de-intensified treatment due to high treatment-related mortality, because you may just not have the supportive care resources to manage that. And certainly, it helps to inform where funds should be directed in order to improve outcomes. So our contributors to pediatric cancer management in the country would, of course, be the government through their national health budget. The medical aid scheme does offer some occasional assistance, though they have really competing priorities and agendas. There are many charities, and I haven't purposely excluded anyone, I just don't have the space, but in recent times, you know, we've seen help from the Sandy Lane Charitable Trust, Barbados Cancer Society, the RBC Children's Cancer Fund, and Variety, and others when it comes to sourcing therapies that we cannot give our children here, sending them overseas or other types of things, and they assist when they're able. We do have strong charity support in that regard, but many of the charities do have competing priorities and agendas, and so you know, sometimes it's just not always possible. I list the Sick Kids Caribbean Initiative here, not really as a charity, but just to point out that we do have kind of a twinning model going with them now for several years. We're one of 6 countries who are part of the initiative. And the mission is really to enhance capacity for care for pediatric blood disorders and cancers in the region. And I'll just point out some of the things that they've been able to help us achieve. They've been instrumental in training personnel, oncologists, myself included, and nurses, as well as continuing medical education for many staff involved in the management of pediatric cancers. They've been instrumental in facilitating equipment for case consultation by teleconferencing. They've facilitated specialized investigations like hematopathology tests such as flow cytometry, cytogenetics in some instances, and histopathology investigations that we're not able to get here. And this is ongoing, but this is not infinite, and really needs to move to the next stage of sustainability or be taken up by the next group who will move to make this a more sustainable occurrence. They've been actively involved in system evaluation, as I've pointed out, but also specifically research and advocacy, as well as policy recommendations. There's a current push to try to incorporate the pediatric oncology nursing program that was part of the initiative into the regional nurse training programs as a module within their training. And this would really enhance the nursing curriculum so that we could see community-based health workers with a greater baseline of knowledge of childhood cancer, which would help to improve the accuracy of diagnoses and prevent referral delay. So I really see then the next steps to translation of the improvements we have made into a national childhood cancer strategy, which would really have the greatest impact and establish capacity that is sustainable. We would address the minimum standard of specialized care accessible to all young cancer patients, as well as establish targets that the country can work towards to better equip our health system. And for this, really, we need immediate increased political attention to childhood cancer, acknowledging that there is really significant impact to be made here because children really do have a good chance for cure when they're diagnosed early and when they have access to treatments. We need enhanced public awareness, as well as we will need regional collaboration going forward as well. So how do we entice local and regional political involvement? I think probably framing policy on childhood cancer care as an opportunity for diagonal health system strengthening is probably likely the only way. For example, you know, we really need to move closer to linking our current childhood cancer registry with the established Barbados National Registry Cancer Division. I think they have had maybe some of our information, but there isn't a firm relationship as yet. And, you know, enhancing their capacity for dedicated personnel and their infrastructure that they could take on our registry, you know, just as a boost to what they already have going on might be the way to go, as opposed to doing it on our own. Accreditation of the QEH as an oncology center by international standards. I know that recently the QEH completed a hospital-wide accreditation process back in 2018, where they focused on some key areas like baby-friendly hospital initiative, laboratory accreditation, etc. And maybe prioritizing an accreditation process with a focus on oncology care accreditation could then couple both adult and pediatric oncology services, acknowledging that pediatric oncology has small numbers, but any quality governance and infrastructural improvements would impact both services. So upgrade of our oncology pharmacy, transfusion services, etc. This would most certainly not just even impact oncology, but the hospital service delivery on a whole. We may even see then development of standardized treatment protocols to help drive data-driven procurement of medications, etc. And we do need to group with our regional colleagues and governments to have a more unified regional drug procurement strategy for oncology medicines and the other medicines used in supportive care for cancer patients, acknowledging that individually as countries we may have small numbers, but we may have better bargaining power with many big pharma companies if we can approach them as a group. And so with that, these are some of my references, and I thank you, and I look forward to any questions at the end of the question and answer section. Thank you.
Okay, thank you so much, Dr. Browne-Farmer. That was an incredible presentation. And I think it really provides a spotlight to medical care and oncology care, specifically pediatrics, in nations other than kind of North American. I think we tend to think of cancer care in the context of adult oncology. Being an adult oncologist, I know we have the value of having of numbers and massive amounts of trials and finances and pharmaceutical companies. And this really provides insight into the heroic work that's being done by you and your colleagues at in Barbados at Queen Elizabeth Hospital, where you're providing care to patients with limited resources and an incredibly subspecialized field. So I think this really highlights the need for communication and cooperation. And it was an excellent talk about how, you know, a lot of the problems that we deal with in oncology and a lot of the challenges that we deal with are amplified at the level of pediatrics when you have such a rarity of disease, but also in a smaller country where the resources may not be as plentiful. It was an excellent talk. And I think that segues very much into our next talk, Rebecca Jacobs, who is a clinical social worker at MSK Kids. And I think, you know, a lot of what she does is assisting patients and their families to navigate the medical system and providing support and coping with the emotional and social and physical impact of a pediatric cancer diagnosis. And I think that's much of what we've been hearing today, that it's a unique challenge that families and patients have to deal with. And it's each person has a different walk. They have a different path. So Ms. Jacobs graduated, we have a lot of New Yorkers here. Ms. Jacobs graduated from Columbia Medical School and then stayed on at Columbia doing her fellowship in pediatric oncology and hematology. And after graduating, went on to Cornell and then ultimately back to, MSK Kids, at where she's been about 1.5 years. She's beginning to further her social work studies for training in the National Institute of Psychotherapies, and she'll be combining this with a psychotherapy certificate while maintaining her current job. She's going to be speaking about, you know, much of what we've been talking about today, the all-important topic of psychosocial aspects of pediatric cancer. So Ms. Jacobs.
Hello. Thank you so much for the introduction. So I am going to share my screen. Thank you all so much for coming today and for giving me the opportunity to speak today. So I am a pediatric social worker at Memorial Sloan Kettering. I specifically am the social worker. I cover mostly acute lymphoblastic leukemia diagnoses, along with blood disorder, severe combined immunodeficiencies, otherwise known as SCID, and most recently sickle cell disease patients. So I think it's also just important to note before I start this presentation that social work can look very different depending on what hospital or facility that you're at. Sometimes, I know this was mentioned in other presentations, but sometimes you'll get social workers that aren't necessarily just in pediatrics. They could be in other departments as well, or you get certain social work colleagues that are specifically outpatient oncology or hematology and inpatient. So you're working with different social workers. My role specifically at MSK is I work both inpatient and outpatient, and because it's by diagnosis, I follow patients and families throughout their treatment trajectory. So it could be at diagnosis, throughout treatment, and then transitioning to survivorship. And we also do have a separate survivorship long-term follow-up clinic too. So once they're off treatment for a certain amount of time, they will transition to clinics most likely. Also, I think through any sort of transition, it's also just important to consider, like everyone has said before, different psychosocial impacts, emotionally, physically, spiritually, and so on. So I'm just going to briefly go over social work role. I'm trying to make it as general as possible, and specifically at MSK as well. And then we'll go over psychosocial aspects and how social work plays into supporting patients and families. So the goal is really to help support patients and families and try to remove any barriers to care throughout treatment trajectory, or at least address barriers to care, recognizing that there are a lot of different barriers to care. And we really hope to amplify coping skills that the family either doesn't have yet or already has or is struggling with, and really help to emphasize strength and resiliencies in the work that we do. So we follow, like I mentioned, we follow patients and families throughout treatment to evaluate and address changes in family needs in whatever capacity that means. And this could be in a lot of different means. And it could be someone's coming in with a new diagnosis. It could be someone's transferring care from an outside facility, or we have a huge international population too, so they're traveling overseas for treatment. And we really strive to understand patients' experience and impacts of cancer using a strengths-based lens, as long as a broad lens, to understand everything in the most comprehensive way possible. Some of the ways in which we do this is individual, family, or group counseling. At MSK, we have a lot of different types of groups that people can participate in, and also addressing psychosocial barriers, as mentioned before, can include transportation, lodging, hospital and community referrals. I know transportation was touched on, and I will definitely touch base on that later in the presentation. And we also have a lot of we collaborate with so many different people we take a multidisciplinary approach. I also think it's important to know, in terms of when we're talking about pediatrics, who are we talking about? So at different facilities, this could be different age groups. At Memorial Sloan Kettering, we actually see pediatric patients up to age 39 approximately. So we have a very large young adult patient population, which could also impact different access to resources, which I'll get into as well. So, okay, so how do we address psychosocial needs? These are just some of the bullet points that I'm going to talk about in more depth. So emotional support and counseling. We help families cope with psychological impacts of dealing with their cancer diagnoses. And this can include different aspects of therapy in terms of psychotherapy or cognitive behavioral therapy, which is how our thoughts, our behaviors, our feelings are all connected. Psychoeducation in terms of talking about diagnosis in the context of other psychosocial issues, mindfulness techniques, this could include journaling or breathing techniques, things like that, and stress reduction. We work alongside child life specialists who specialize in medical play and helping prepare children and their families for procedures or undergoing certain treatments so that they can familiarize themselves with that. And guidance and support, and we also have a psycho-oncology team too, made up of psychiatrists and psychologists that also provide individual or caregiver counseling to parents, caregivers, children, siblings throughout their treatment trajectory as well, and even beyond that. And if appropriate, we refer out to the community as well. So getting a cancer diagnosis and entering this sort of medical world unexpectedly can be very overwhelming for families. We support families in terms of just adjusting to a hospital setting in general and adjusting to medical terminology, because there are so many different types of language that are used that families can feel very overwhelmed by. We also definitely, because we see such a wide array of children at all different ages, we help support families in terms of talking to their children about their diagnosis. And this also includes sibling support, which I'll get into later, but we really help to try to identify age-appropriate language alongside child life specialists, because, and we actually do encourage them to name their diagnosis or use the word cancer for most ages and different languages, just because recognizing that they are entering into a Memorial Sloan Kettering Cancer Center. So if school children can read, it just creates a more trusting family environment and can allow the child to actually ask more questions or express how they're feeling, and it helps to foster greater overall communication to create a better sense of trust. And so this can also, navigating a medical system can also include, like I mentioned before, transition, so beginning treatment, what that's going to look like for families. This also includes the fact that a lot of the times there is a financial toxicity related to treatment. So families that may be working are unable to work anymore. Caregivers have to rearrange their caregiver schedule to take their child to treatment, and they may have several other children at home that also need to be cared for, especially also if you're coming from overseas, you may have an extremely limited support network, or you could be an only parent or caregiver for a child, and that can get really, really stressful and tricky. And not only beginning of treatment, but like I mentioned before, transition to survivorship, if there is a relapse or recurrence of cancer, and a change in treatment plan. This could also include supportive care, palliative care, and we could also be talking about bereavement or end of life as well. And like I said, we also provide a lot of caregiver support to caregivers because they are experiencing their child go through cancer treatment. Crisis intervention can include a wide array of different needs. So this could be medical emergencies. If that happens, we often are called to help provide caregiver support during that, or acute emotional distress, outside psychosocial stressors, including custody or guardianship issues. And we have a whole legal team that reviews that paperwork as well. But in terms of communication, who we can communicate with, what information can be conveyed, we want to help support families and team members through that as well. We also deal with crisis intervention relating to immigration status. That happens a lot, or even just anxiety and depression we see all the time in terms of managing a cancer diagnosis. So those are some of the things. Also thinking about in terms of abuse or neglect, domestic violence, and we also do suicide assessments as well. It's definitely important to recognize that because we're following patients throughout their treatment trajectory, we are continuously doing ongoing assessments. So our assessment that we do at the beginning of treatment will likely not look like the assessment we're doing the second, third, fourth throughout treatment. They really vary. A barrier could be addressed, and then another barrier to care pops up as well. So care coordination and treatment planning. So through our strong understanding of our patients' and families' mental and emotional health, as well as social, cultural, financial circumstances, we really help guide other members of hospital staff in providing sensitive, compassionate, and effective care to patients and families. And in addition to communicating with medical staff, interdisciplinary team members such as child life or chaplaincy, we also help to coordinate different family meetings between medical teams and patients' families, just because we recognize that there's so much information coming from different places at once, and it can be overwhelming to family members. If we feel that they may benefit from an interdisciplinary team meeting to really go over the treatment plan and go over any questions that the family may have, or give the family the space to express how they're feeling. It could be frustrations, it could be feelings of anger and sadness, so that we're really all hearing the same information and can help to present a united front, and also help to advocate for patients and families as well, knowing that. Behind the scenes, at Memorial Sloan Kettering, we have psychosocial rounds weekly where we get the opportunity to collaborate on cases, and it's really nice. We often have different people from the medical staff actually participating, so that we're all really working together to make sure that we're talking about these patients and families. Although recognizing also in my role as a social worker and in the social work role, we also want to protect patient. We often get into conversations that lead to really personal information. So we also want to respect that as well. And at the end of the day, we really just want to protect patient safety. We want to ensure patient safety and family safety as well. We also have we participate in medical rounds as well. So it's nice for us to be able to hear the medical information, although sometimes maybe we get lost in the medical terminology, but we're hearing the information, and we are given the opportunity to also process that and ask questions so that we can better help and support patients and families. And then connecting to and navigating resources. So this really dives into certain barriers to care, such as logistical aspects as transportation or housing. You can have a family who is coming here for treatment from anywhere outside of New York and really not having a plan because a lot of patients and families are thrown into this situation. So we do assessments in terms of if they're eligible for temporary housing, and then support them through finding more permanent housing throughout treatment if needed, depending on how long their treatment is, how often they're coming to the hospital. And then along with transportation, and recognizing that all of these things cost a lot of money. So navigating cancer treatment, especially when there's an extreme lack of income. And I think that all of these things are amplified, especially during COVID and the pandemic, recognizing that a lot of people lost jobs and different financial supports that they even had and were hanging on to during treatment. So that's added an extra layer of psychosocial barriers and needs to patients and families. Luckily, we do have a food pantry at MSK, which I know many other facilities don't have. So we're able to help a lot of families and connecting them with those resources, and also referring to the community in terms of local churches or different organizations that can help out in terms of wherever the family is identifying as a need. We really also do collaborate with outside organizations. So this could be referring to, if cancer is one aspect, of course, of a family and their needs. So if there are also other medical needs that need to be addressed besides a cancer diagnosis, or even that in and of itself, we have community social workers that we can refer families to help them navigate appointments. This is also referred to as health home. So really providing that support beyond the hospital walls, although we try our best to be able to follow up with patients, not only when they're in the hospital or here for appointments, but checking in on them as well. So that is that. And then I wanted to get into talking more about how we do these things. I know I mentioned a lot of these things, but I really want to emphasize the social work role as we are a resource for teams and families. We always encourage patients and families to ask us questions, even if it's not necessarily anything we know about. We can help to guide them to the right person, and same with the medical team and interdisciplinary as well. And I really think that ongoing communication between the medical team and social work and the interdisciplinary team is the best way to work together and to optimize patient care and support. It's really helpful when we as social workers know about medical updates so that we can appropriately prepare to talk with patients and families. We're up to date with the latest medical information, and vice versa. If there's a change in family dynamics or in status or needs of a patient or family, it's important for us to communicate that to the team as well. So I touched on a few of these things, but I wanted to get into them in more detail. So one of the things that come up a lot is that we have school-age children receiving treatment, and they're most likely inevitably going to miss days of school. So luckily, we actually have MSK teachers that are through the Department of Education who can provide hospital instruction, both inpatient and outpatient, to children, which is really, really nice because it provides them with a personal individual face that can help them to kind of go at their own pace and really understand where they're at in treatment. This also includes, right now I know that there's a lot of remote learning going on. So families have the option at certain schools to either for their child to participate via learning alongside their classmates, or go through home instruction, which is a process through the Department of Education in different states, where you actually enroll your child and transition them into a one-to-one, working with individually one-to-one teacher for a certain amount of hours per week. And that varies depending on age and grade. And this we help support families and patients during this transition. It can be really tough because a lot of children really love the socialization of going to school and learning, and it can look really different when they're not allowed to be alongside their classmates anymore. And then transitioning back to school, either on or off treatment, can be a big transition as well because they haven't been in school for X amount of time, and we really help to support that. Our child life specialists too are really good at helping patients and families talk to their schools. So are we, but they can actually go into schools and provide education about their cancer, the child's cancer diagnosis, so that everyone, even other kids, can have a good understanding or general understanding of what their classmate is going through. Different resources. There are a lot of different resources out there for pediatric cancer patients. They vary greatly based on certain eligibility criteria determined by the specific organization along with individual needs. So examples of this can be pediatric cancer nonprofits, cancer-related organizations that host events or community support groups and programs for patients, families, and siblings. I know right now during the pandemic, a lot of that in-person events and things like that are not happening. So it's actually, some things have moved virtually, but there's a lack of, that in-person support right now. But we actually at MSK, we have a whole, I'm part of the Siblings Day committee. So we have when kids are out of school, we have certain days where siblings can come to the hospital and kind of see, because a lot of siblings wonder where their parents or caregivers or siblings are going all the time. And this is an opportunity for them to kind of explore the hospital, connect with other kids that are going, or other siblings that may feel the same way as them. And we really encourage them to be expressive and do different bonding activities. So it really gives them the space to unite with other siblings and also form a different connection with their family members as well, and see where their sibling, their brother or sister is going to get treatment and what that's like as well. And in terms of financial needs, this also availability for financial assistance does vary greatly based on age, diagnosis. There are certain, I'm thinking of Leukemia Lymphoma Society, which is very specific to diagnosis. So other children with cancer would not be eligible. A lot of pediatric organizations as well for financial assistance go up to a certain age. So like I said, we have a lot of pediatric patients who are over the age of, who are in their late 20s who won't qualify for assistance from a lot of organizations. So that's a big barrier that we deal with as well. There's also a limited number of applications. They also do vary, not only by age, they vary by location. There are certain organizations that only service certain areas. So we really have to, that's why our assessment is very important in terms of figuring out who can qualify for what financial assistance. We also help to connect families if they're eligible for certain government entitlements. So that includes supplemental security income, which is because patients and families have cancer diagnosis, it does make them likely eligible to receive these benefits, and that varies. But so another thing could be food stamps. I really think that just depending on where you're at, the social worker is the best person to contact regarding community assistance, because it's determined by social work assessments and availability and greatly variable eligibility criteria of specific resources. I think that is it. And there's a lot, but I really thank you all for again, coming today and taking the time to speak with me. And if you have questions, I'm happy to answer them during the Q&A.
Thank you, Rebecca. That was an excellent presentation. And I think it highlights the multidisciplinary approach of medical oncology and specifically in pediatrics. And I think you really highlighted the unique challenges that families have, that it's not a diagnosis simply of the child, but of the entire family. And you really provided a breadth of information in terms of how you support not only the parents, socially, emotionally, as well as financially, and recognizing the barriers or the challenges that they face, but also recognizing that they are a family unit and there are other things that are involved aside from just the cancer. I think having trained at Memorial, I know there are ample resources, and it's amazing how, especially in the pediatric department, these resources are spread throughout different socioeconomic classes, people from different countries, and to provide the resources that these families need. So it was an excellent, well-rounded presentation for us to see how we need to be a medical team combined of not only the doctors and nurses, but of our social workers and other services that help families cope. So with that, I'm gonna, I think, transition over to Dr. Paris, who's gonna continue.
Thank you, Tracy. Great presentations, a lot of information. They've gone from the didactic, and now we're going to the practical, or actually we're going to look at patients and their families to see the impact that cancer has had on families. And a lot of it will relate to, of course, what Becca presented just now. Now, I have 4 pediatric families here who have had cancer or are going through treatment. 2 have actually completed treatment, and 2 are going through treatment. 3 are my patients, and 1 is not my patient. Because we kind of running out of time very rapidly, I'm going to go very quickly and introduce them to you, and then we can talk some specifics about exactly what experiences they've had. So I'm going to just go to my slides here and kind of quickly run through the patients that we're talking about. First patient, LR, and Mr. Ramey is here. His daughter, Leanne, is my patient, and she's currently 5 1/4 years of age. Came to the office in late January with a history of swollen neck, swollen gland in her neck. And on physical examination, the swelling was a bit suspicious. We have a way of telling whether a swelling is suspicious or benign. So the thought was, you know, this looks suspicious. Let's get some blood work done and send her over to the Children's Hospital. Children's Hospital being the Cohen's Children's Medical Center. I'm in New Hyde Park, where I am on staff. And initially, the oncologist thought that, you know, we're not sure basically what it is. They did a bone marrow, and they looked at the smear. Let me backtrack. They did a blood smear, look at the smear, didn't see any malignant cells, and opted to follow her at that point in time. Now, 1 month later, she went back, and of course, then the leukemic cells were very evident then, and she was diagnosed with ALL. And the protocols that were mentioned previously were started, and she's still currently in treatment. And we'll come to that when Mr. Ramey comes on later on. And then the second patient I want to mention is a 16.5-year-old adolescent female, diagnosed with Hodgkin's lymphoma 2 years ago at age 14, presented with a lump in her neck and mild weight loss. And she was treated initially at SUNY Downstate, and similarly went into remission, but relapsed after 6 months, and then was referred to MSK. And maybe Becca knows her, I don't know. But she underwent a bone marrow transplant in September of 2019, and will be completing chemotherapy in less than 2 months, and she's doing quite well. And Carolyn Grisette is another patient, and she's here today with her parents, Carson and Valerie. I first met Carrie Lynn, as we call her. She came to the US in March of 2012 with a confirmed diagnosis of AML, acute myeloid leukemia. The problem was that she needed the bone marrow transplant, and bone marrow transplantation was not available in Barbados then, or now as far as I know. So we were in a dilemma because there were some barriers to getting her treated here. Barriers being her non-resident status and insufficient medical coverage. The Carsons did have good coverage, by the way, but the hospitals deemed that it was inadequate. And she was declined treatment at Long Island Jewish Medical Center, Columbia Presbyterian Medical Center, on the basis of insufficient medical coverage, even though one of us was on the staff at Columbia at the time, and I was on staff at LIJ, but they couldn't convince them to take her. Since then, but at that point, the next option was to try to get her into a facility that would be appropriate. And I called up St. Jude Hospital in Memphis, Tennessee, and guess what? They took her. And I let them tell you what St. Jude's is like, because once you're admitted to St. Jude, you are covered completely 100% for everything, and they will explain that to you, what that means specifically. And then Daniel Mascu, another of my patients, he's now 9.5 years old, diagnosed with a brain tumor at 5. He came in with headaches, and as was mentioned in the previous presentation, everybody gets headaches, kids get headaches. It's not the first thing you think of when the kid has a headache, that they have a tumor, a brain tumor. But if it's a persistent complaint, as it was in his case, you get suspicious. And MRI was done, showed a mass in his brain, admitted to Cohen Children's Medical Center, LIJ, had neurosurgery, astrocytoma, and obstruction of cerebrospinal fluid, which surrounds the brain and flows through to the spinal column. And he did well, initially no chemotherapy, but in 2017, there was some regrowth of tumor, and he got some chemotherapy then and has been stable and doing quite well. So those are the four family units that I want to have talk to us today to give their experiences, with the diagnosis. And the first question that I have, and in fact, perhaps you can bring the Carsons, bring Carson and Valerie and Carolyn Grisette onto the screen so that they can address for us a couple of things. And life before cancer, life after cancer, adaptations, even briefly your experience at St. Jude, and complications that Carolyn experienced and how they've been handled. Okay, let's go to Gabrielle then. Let's go to Gabrielle and her mother, Mrs. Codrington. I know they are on for sure. Gabrielle, hi.
Hello.
Okay, so tell us about your feelings when you heard this diagnosis. What went through your mind? What do you think? What impact it had on the family? Give us an idea as to your feelings initially.
Okay, so when I was diagnosed, the doctors weren't very straightforward with the diagnosis. They came in and out of the hospital room saying, maybe it's this, maybe it's that. They really never gave us a straightforward diagnosis saying that it was the Hodgkin's lymphoma. I didn't feel too bad about it because I did my research and found out their cure rate, the survival rate. So I was feeling pretty hopeful about it. And as for the effect on the family, of course, they were pretty worried, especially since my aunt died of cancer a few months before I was diagnosed. So it was a lot of stress on the family, but after the 2 years and going through everything, we've been doing well.
Oh, fantastic. Okay.
And this is Michelle. This is the mom. We're in two different places. But one of the things that they spoke about in Barbados was the medication. That was one of the things that took my sister because the lack of medication too. So we were fortunate enough up here that, we went to SUNY downstate. It didn't work out for us down there. And then we were referred to MSK, which is like a complete eye-opener for us. And from the time we went to MSK, everything has just been so straightforward. We got answers. We got social workers, like she said, that everything that she said about the social work, it worked for us. We had every one of those things were available to us, and I just wanted to say that. Okay.
Gabrielle, another question for you. How about your friends and other family members? Did you guys were upfront with your friends and family from the very beginning, or it just happened gradually that you revealed what was going on with you and the family?
I'll answer it, Gabby. I did when she was diagnosed, what I did is I actually put it on Facebook. People called me and told me it was a bad idea to let people know that. Some people actually thought that, it was a joke. Somebody had stole my Facebook account to say something like that. People were asking me, why would you say, that your kid have cancer? I was not embarrassed about it. I was concerned. I wanted to get, we're a spiritual family. We do a lot of praying, but we still know we have to listen to the doctors. So for us, it was like, we didn't hide it. We just told everybody, hey, this is what it was.
Okay, great. The other thing, just to ask you before we move to perhaps get bigger at Grisettes again, how did it affect school for you? Did you have to quit school?
So during the first diagnosis in 2018, I did not quit school, but I had to leave my school and do homeschooling with the DOE. The process was not too easy, especially with certain teachers. But then after the relapse, during the second time, we decided to do school virtually. So I used Skype to attend my regular school, and I also used robots to actually roll around the school and go to classes as I normally would.
Okay. And currently you have full activity going about your life like a normal teenager, or any restrictions that you observe?
She's on mute.
Ms. Codrington, you can answer that, Mrs. Codrington, since
no, one of the things that happened is because she had a stem cell transplant in the hospital, so we were in there for like 6 weeks that we stayed in the hospital, did not come out. But even when she came out, you couldn't have people around you too much because you don't want anybody have a cold with anything with her immune system. So we were just shut off from people, but our people knew. They talked to us on the phone, on the computer, but no one was allowed to come to the house with everything that was happening. Like she said, she did the Skype school. So when all of this, everybody's learning virtual, we were already in this now over 2 years. So for us, it was just another day.
Right, we've had a good outcome here, Ms. Mascu. As you know, he's now, in remission and being followed, of course, very closely by the various specialties, oncology, neurosurgery, etc. And that's fantastic. And he's growing very nicely and doing well. Thank you for that. Appreciate it. It was a bit, there was some interference, but we got the gist of what you said, and really appreciate that very much. Now, are the Grisettes available now?
Yes, we can hear you.
We're hearing you.
Oh, fantastic. Okay, great. So we said that Carrie came up. She had a diagnosis already made. She couldn't be seen in New York for financial reasons, even though you had great insurance by most standards, but the hospitals felt that the potential complications were such that it was very unpredictable how much it would eventually cost because of potential complications with bone marrow transplantation. And so we got you into St. Jude's Children's Hospital, and take it from there, because one of the things that is fantastic about St. Jude's, and you can please expand on this, is that once you're a patient at St. Jude's, they will do everything that's needed: housing for the family, transportation. In fact, they paid you away from New York down to St. Jude's, down to Memphis, I remember. And they'll fly you to Barbados, fly you back when you have complications. So all that stuff, and I'm making a pitch here, by the way, you can probably hear me say it, that if you do any charity donations, that's one place where the money is well spent. So Carson, Valerie, Carolyn, take it from there and give us an update, life before cancer, what life after cancer, and where you are now in the course of all that has happened to you since you were 11 and you're now 20. So that's about 9 years or thereabouts. So go right ahead, please.
Okay, hi everyone, and thanks for inviting us. As you said, Carolyn she first got ill when she was 11, and that diagnosis happened in March 2012. And when we look back at it, she was showing symptoms from about September 2011. So we thought it was one thing the next. The doctors were thinking it was just a change because she was moving from primary to secondary. So there were lots of ideas of what was wrong because she was constantly tired and losing weight, and we couldn't put a reason behind it until we got the diagnosis in March of 2012. Anyway, long story short, we had a lot of hiccups trying to get her the right treatment, which wasn't available in Barbados. And we understand, small island and small budget, but this is our child, so we wanted the best opportunity for her. So Dr. Paris knows the ups and downs and the hoops we had to jump through to eventually land at St. Jude. And I think that was the first thing we actually breathed a sigh of relief. They took care of everything. And I mean, the way they went about taking care of her, it was just phenomenal for us. So she was cancer-free. Remind me of the dates, Caroline, from which date? September. She was cancer-free from September of 2012, but we've had some complications since that we've been dealing with. One being that she had renal failure, which she still has. We got a kidney transplant for her from myself, but that eventually failed. So she's back on dialysis now, twice a week. She also, one of the long-term effects now is she had GVHD, which affected her lungs. She was being considered for a lung transplant at St. Louis Children's, but they didn't think she was bad enough to get that transplant. So she has since been put on a ventilator. So she now lives on a vent. She's able to come off of it a couple hours a day and still be comfortable, but in essence, she spends most of her days on a ventilator. Luckily, she has a portable one, so we still get out and do things, and she hangs with her friends sometimes, but you can understand the challenge of walking around with a 20-pound machine wherever you go, if it's gonna be for an extended period of time. Generally, Carolyn is doing well. I think most of her problems now are more mental and emotional. She's in no pain, but you know, not being able to function as a typical person her age can be quite stressful. And she has to spend a lot of time around her parents. Unfortunately, we're no fun for her. And she tells us that without any remorse. But Carolyn can speak for herself, but she doesn't want to, she's shy. But we're so grateful to have met you, Dr. Paris, and to be able to get treatment for Carolyn at St. Jude, which we would not have otherwise had. I can tell everybody that when they see the ads for St. Jude to donate, it's no lie. We don't have to take care of anything. They send all her medications. We're back in Barbados now. They send all her medications. They send all her supplies, down to gauze. The most simple thing you can think about, it comes by FedEx to her. Her equipment, she has 2 ventilators that they purchased in the event one goes badly. And now that we can't travel, because they've agreed to see us once a year, but we haven't gone in a while because of COVID, but we send the equipment back, they service it. I mean, they literally take care of everything. And they even gave her a wheelchair because of her issue with her lungs. She gets short of breath very quickly. And she has a mobile chair that when she drives through the hospital, everybody looks back as though it's a Mercedes-Benz that drove through it. I'm not kidding. But we're hanging in, we're grateful.
Yeah, and in fact, Carolyn has lots of support. There's a Carolyn Grisette Foundation now. You might have heard of it, some of you. It's based in
Atlanta.
In Atlanta, Georgia, right, exactly. And I did send, it was inadvertently, I guess I forgot to send the notification of this symposium to them. So I don't know if anybody from there has been able to log on, you know. But yes, go ahead.
Man, Bino was on earlier, so I hope he's still there.
So he got it then. Okay. Yeah, Wayne is very much involved in the foundation, helping raise funds in support of Carrie. So that's great that he was able to get on. Appreciate that. So this was an example of a barrier that you overcame. You know, got up and you acted, brought her here, and we got her here. But just to mention, not to divert, but there are other things that CAMSA and BACA have done in the last 4 or 5 years. We have sourced medications for both the hospital. A particular physician called about a particular medication that was not available, and we were able to get it and get it down for the treatment of that particular patient. It was an adult patient, actually, come to think of it. And then a friend of mine called about her employee whose son needed a medication that was not available at the time, and we were able to source that and get it down to them too. So over here, I think we're trying to do our part in helping when we can, you know, with shortfalls and shortages with respect to treatment in Barbados. I think I thank you all very much. Is Mr. Remy on at all at this point?
Say that again?
Yeah, you're here, Jonathan? I guess he didn't make it for some reason. But I want to thank the Grisettes. I want to thank Gabrielle Codrington and Michelle Jordan and Mrs. Mascu. Thanks a lot, really appreciate your sharing your stories and putting a real face on childhood cancer. I want to just mention that if there are any questions that you want to pose, you can enter them in the chat and we will endeavor to have them answered by the patient and their families, or after the symposium is over, we can have them answered via email. And I think we're catching up on our timing here. We're going to move now to an update on the Barbados Hospice. Let me just be right with you. Okay, the Barbados Hospice Initiative. We've heard a lot about childhood cancer and the cure rate for childhood cancer, but adult cancers are not doing as well as you would imagine from the presentations. And there's an initiative to build a standalone hospice in Barbados. It's a joint venture of the Barbados Association for Cancer Advocacy and the Living Water community. The Barbados Association for Cancer Advocacy is a Barbados charity that actually was established by BACA, or BACA right here set that up some years ago to help carry out or program activities in Barbados. We had been previously just donating money to different organizations, Barbados Cancer Society, Cancer Support Services, Barbados Family Planning Association, etc. But we thought that perhaps we should now take greater control over activities in Barbados, and that particular entity was set up. And the Living Water community is a lay Catholic community in St. David's Christchurch, and they are headquartered in Trinidad and had lots of, or have lots of hospice experience. So we thought it was a good fit to work with them to try to get us off the ground. But just a few quick definitions. A hospice being a place of rest and tranquility where those at end of life can receive comprehensive, holistic care from a multidisciplinary team of professionals. And then for palliative care, and that's an integral part of hospice care, and addresses pain management and comfort care. That's simplistic definitions. And hospice can be provided in different settings. Could be home hospice, could be institutional, or for example, in a hospital or nursing home, and it can be freestanding. There's no freestanding hospice in Barbados. There's community-based palliative care by the Barbados Association of Palliative Care, and Cancer Support Services, I understand this provides some community-based palliative care. Now, why do we need a hospice in Barbados, you might ask? And things have really changed. There was a time when we took care of our parents as they age, but then there were smaller family sizes, people were migrating, demographics changed, population was aging, increasing chronic non-communicable diseases, etc. And that became a burden as people aged. And there was a needs assessment that the government commissioned actually in 2012 that showed that, or supported the need for expanding the home hospice aspect in palliative care that was occurring. And it recommended that a standalone hospice be established. Of course, there's no money, lack of financial resources in terms of government, and it was low priority. The government commissioned the study, but they had no money to go forward with it. So then, and it did have the support of the NGOs, cancer advocacy NGOs in Barbados. And so here comes the diaspora now. What can we do in Barbados? Because again, BACA, as you heard, one of its primary missions is to help support cancer support services in Barbados. And we thought that we could work to help promote and finally establish a freestanding hospice, as was recommended by the report in 2012. And we would do it not through BACA USA, but through our sister organization, the Barbados Association for Cancer Advocacy, which is an established Barbados charity. So in June 2016, we signed a joint venture agreement with between that local organization, the Barbados Association for Cancer Advocacy, and the Living Water community, which I mentioned was a community that has great experience over 30 years in running hospices in Trinidad and in Saba. The construction costs were projected at 3 million Barbados, or 1.5 billion US. And we looked at the diaspora and said, how could we help accomplish this? And we looked at the US diaspora, the Canadian, and we even looked at the UK diaspora, although that hasn't yielded much fruit yet. And we were able to donate US $102,500, to the effort. And I want to say it right here and now that the monies that were donated came from local Barbadian associations, Combamer Foundation. There's a list someplace that I can share for you and with you, and individuals that donated these monies to go towards the hospice effort. So at the height of our fundraising, of course, we have issues with the economic downturn. Then the election came in Barbados. We had been talking to local business people, got pledges from them. But now because of COVID now, there's a lull or a decrease in interest in the funding of an entity like this. We were worried about COVID. Let's see what happens. We're not giving up on this. We're still going to be pushing in Barbados, pushing in the US diaspora, Canadian diaspora, UK diaspora, and various foundations and fundraising and funding agencies, etc. Celebrities. It's hard to get to these celebrities. You might say, oh, we have celebrities of Barbadian background and we just call them and they'll do this, but it's really tough to even get to those folks. So the current status is that we still have, we're not giving up on the hospice. It's been 3 years now since final approval by the Town and Country Planning Office, and we're not giving up on the hospice. We will have ongoing fundraising activities, limited of course by COVID. We have to strategize and kind of look at different ways of approaching this, and we're gonna get this done. No doubt about that in my mind. So every penny counts. So any donation that you can give would be great. You can donate directly to, if you're in Barbados, to the Barbados Association for Cancer Advocacy, or here in the United States, you can do BACA, the BACA website, or the Barbados Diaspora Collaborative USA website as well. So if anybody really is interested, please get in touch with any of us at BACA or BDC USA and CAMSA, and we can direct you how to go about that. So that would be something that we would really like for you to get involved with, if you could. Let's just, before we finish this section here, let me just share with you the venue. Oh, here's the venue. Here's the, can you see this, folks? It's in Davis area where the hospice is projected to be built on the Living Water campus. This unit here, this building that you saw is Living Water property, the entity that we're partnering with. So that's to show you that. And we also have actually done some construction already, where we've kind of excavated the site. And we had a drone image. I don't see it here on my desktop anymore. In any case, things have happened with the monies that were donated from the United States, and the seed money was provided, and we still have a fair amount of the money provided from up here, because we did indeed have lots of local help, that to help us in the effort. Architects, engineers, etc., donated their time, or else just taking minimal costs for themselves. So I'm going to stop there so that we can run on time and pass this back over to Dr. Tracy Proverbs-Singh. Thank you.
Thank you. And so now this is the Q&A session, and please continue to submit questions if you have them. At this point, we're going to kind of open it up to looking at the questions, I'm going to combine them a little bit. There's some similar ideas. So I think we'll start with kind of diagnosis and navigating the system. This was a thread that was across all the presentations. One question highlighted, how do you identify signs or symptoms in a toddler or any other age group? And then how do you navigate from symptom to actual diagnosis? Both US as well as in Barbados. And I think we heard some of this, but I think the step-by-step of what do you identify and then how do you go about seeking that help?
So I think that's a very, very good question. And it's one that comes up quite often, particularly in the toddler age group, can be very challenging because, as we all know, they really don't have the language to tell us exactly what is going on. And so in a toddler, what you might see is if they're experiencing pain, would be, you know, fussiness out of proportion, in terms of things that may indicate that they could have some abnormalities in the blood count. You could see things like pallor. They just look particularly pale. They're more tired than normal. That could indicate some anemia. You could see things like easy bruising, sort of tiny red dots that we call petechiae that are an indicator that the platelets in the blood might be low. You could see a high fever, but again, all of these things are going to be more likely to be indicators of other common childhood illnesses more than an indicator of cancer. So I think the best course of action is really to seek care early and also to be persistent, right? Because if you think about the rarity of childhood cancer, and Dr. Browne-Farmer also alluded to this, many pediatricians may never have a patient with cancer in their panel. So, you know, I think in the US, the perception and the awareness is probably more heightened, but you may very well have a pediatrician that may just not have it on their radar because of whatever reason. So they may come in with a fever or other typical symptoms, and there may be no move to, say, draw labs, which would have indicated an abnormality. So it's really about sort of being persistent. I always like to say that the parent really knows their child best. And so if you think something is off, really keep going back. And if it means getting another physician to see your child and maybe have a different perspective, then you are really your child's best advocate. So I would say seek care early and be persistent.
Thank you. And Dr. Browne-Farmer, is that similar to your experience?
Yeah, I would say, you know, just as Rochelle said, how the child presents is going to really be specific to what type of cancer they have. So there are probably about, you know, 8 to 9 categories of, I guess, suspicious signs and symptoms that you should bear in mind. And I think they were in the initial presentation. So things like a toddler who normally is walking and suddenly they don't want to walk, they want to be held. You may not be able to necessarily see anything, but those are signs and symptoms that you should explore. Again, things that may indicate a blood problem, like being pale, having lots of bruising that you can't identify, even persistent respiratory symptoms. We don't think about it when we think about cancer, but it's really important because a child who's having a persistent cough, and you know the pediatrician is doing what they normally do in terms of saying, okay, well maybe this is asthma, or maybe this is recurrent viral pneumonia or something like that, or even maybe it's a bacterial pneumonia and you're treating with antibiotics and it's not getting better. The physician really should challenge themselves to, you know, look a little bit deeper in situations where children are not responding to the usual treatments, and the parents should, you know, be persistent in terms of voicing their concerns. And it's not necessarily the fault of the physician. You know, you just, as many of us will not see children with cancer, but we do need to have a high index of suspicion, and families should raise that concern openly with the physician if they are thinking about it. You know, is this something that you normally see? Do you normally see a child come back with 4 pneumonias in the space of 2 months? And could we look into it closer? Most pediatricians would not mind moving further with you.
That's excellent. And I think in transitioning from, you know, developing a diagnosis, and once a family is finally faced with the diagnosis of cancer, what are some of the tools that families can use to navigate the system in order to inquire about what the best course of action is? I heard from a lot of the families, as well as all of our speakers, that you know, finding the right place for treatment and finding the right treatment, we heard that diagnosis is critical because you have a treatment recipe. And if the diagnosis is incorrect, your recipe would be incorrect. And so what are the challenges that are faced? And these are some of the things, both in the US, but then for Dr. Browne-Farmer specifically in the Caribbean, and what are some of the tools that can be used to help navigate that system? And also Rebecca can comment on how you help families navigate, you know, where the best option is for their treatments.
Yeah, so I think it probably starts with, you know, getting the initial, maybe referring physician to be kind of upfront with where they're going with next steps, and say to them, you know, can we also have input from, you know, an oncologist if you think that there is a possibility, because there are things that we as oncologists can contribute to thoughts on the workup and progression, sorry, of the move to get an early diagnosis. So it's not that we don't need our colleagues in terms of making that diagnosis. We certainly need the referral to the surgeons and so on for biopsies, etc. But a lot of times, you know, the way, at least in our setting, the way it's done, you may be referred to one of the hospital outpatient clinics, not as an urgency. When you are seen, then there's sometimes delays in terms of scheduling procedures, and then there may be further delays in terms of processing specimens, just from the sheer volume of specimens that have to be assessed, not necessarily being flagged as something that is being urgent. And then in some of our situations, actual additional testing may need to be done outside of the hospital, and so we can help to drive that. So you may not necessarily need to see us right away, because you know, until we have a definitive diagnosis, we would not be necessarily initiating treatment. But we want to know about those things because we definitely are able to help in terms of helping to direct the path to getting the diagnosis.
Yeah, and I think you speak to, you know, in adult oncology, frequently the pathology is sent for molecular testing and genetic analysis. And I know that's something that oncologists do play a role in early on in the diagnosis. Additionally, is Rebecca there to discuss kind of what are the barriers that you see in initiating a family in treatment and getting them started? Because we heard from some of the families that there was sometimes some hiccups and moving around to get treated in terms of insurance and the ideas of what needs to be done leading to starting and initiating their treatments.
Yeah, definitely. So luckily I can't speak to other facilities. At Memorial Sloan Kettering, we have a patient financial services department. So they really answer all insurance and billing related questions. So I usually provide their contact information to patients and families almost immediately. Otherwise they're referred through another modality, but it's really helpful for them to get all of that situation. They're often speaking with them before families come, just to make sure that everything's kind of in order and you're addressing any sort of barriers to insurance or billing or things like that. I'm also thinking about how there are, in terms of access to care, so some people might prefer come to MSK or another facility for a consult while attending another hospital because it's closer to their home or it's easy for them to get to. And then us or whoever the consulting hospital will make recommendations saying we're in agreement with the treatment plan. This is what we would do differently. In terms of bone marrow transplant, we also see patients that come from an outside facility to get transplanted, and then they go back to their treating hospital that they were getting treatment at before. So sometimes that can be adjustments for patients and families when they come from somewhere else and they adjust to a new hospital setting where there are different resources and roles, and then going back. I also think that's where communication is really important. We try to touch base with the social worker from those facilities to help with transition of care as well.
Yeah, I think you're talking about all the things that could help everybody in any facility ask the right questions and make sure they're seeking out the proper resources. And I think that brings to a couple of questions or some similarities in terms of looking at access to care in Barbados and how can we create, is there a consideration of creating a regional cancer center that covers multiple different areas and looking at, joint savings or joint resources within that area and kind of complementary. Somebody asked in Barbados, is there a way to kind of combine the oncology and healthcare referrals in a network that creates a resource? Because I know this exists in the US and in multiple regional associations. Is this possible in Barbados as well? And maybe Dr. Brown. She's muted.
Okay, I couldn't unmute myself, sorry. Yeah, so sorry, I remember the last part.
Yeah, the question was specifically about the regional, like to form some sort of regional cancer center. I think this is similar to your alliance, but where you have joint savings, joint healthcare resources, having patients, participate from other hospitals across the Caribbean.
Yeah, so a physical regional center, I don't think that that's something that has necessarily been discussed as yet, but certainly a network of physicians, yes. So the Sick Kids Caribbean Initiative, that's one of the things that they are kind of embracing with their initiative in terms of enhancing capacity across the region. So if you increase the number of oncologists in the region, you can improve care that's available to everyone. And we do get referrals from other islands. In fact, we have somebody with us right now from St. Vincent. And that happens at various points throughout the year. There are some financial challenges to that because there does need to be some government to government engagement in terms of having children move from country to country to get care, because individual governments will not necessarily cover the care for a non-citizen, but definitely getting care where there is an oncologist available in one of the islands is more affordable than, say, sending that person to the States or some other developed country for care. And then the last part was, can you just remind me again? In terms of an actual, like maybe network where we can upload and share patient information. In the Caribbean, we are very behind in terms of electronical medical record systems and so on. We don't yet have that at the Queen Elizabeth Hospital. There have been some moves towards it, but that has been on hold for some time, and definitely now in the current climate, not looking as though we're going to be moving towards that anytime soon. And I'm sure the situation is the same in other Caribbean centers. And so a situation where we can kind of communicate with each other through a set network a physical network is not on the cards at this point in time. But we definitely do communicate as individuals in various countries where we treat cancer patients. We know each other mostly through the initiative, and we help to try to coordinate care for persons in other countries where they may not have access to oncology care.
And I think it's, you know, you brought up the point of technology, and it's something that Gabriella brought up, where technology played a large role in facilitating not only treatment, but coping with the cancer diagnosis. And I'm curious because there are a lot of gaps that you identified in your presentation where technology may help to bridge that gap, where you have, you know, a combination of volunteerism where people would maybe review pathology, look at diagnoses, send pathology across the internet to be viewed, because technically speaking, you don't need to physically see it. You just need the picture of it and be able to zoom in.
Yeah.
And these may be ways to bridge some of those gaps.
Yeah.
Can anybody else have you speak towards the technology aspect, and then maybe Rebecca could bring up how you guys use technology as well.
Was that for me or?
Yeah, the technology, using it to
again, the Sick Kids Initiative helped significantly with that in terms of we have like a dedicated teleconferencing room where we can discuss cases. We don't necessarily have to use that room, but we do have a kind of a online workspace set up with them where we can discuss cases, share imaging, just like you said. They have facilitated, unfortunately for actual physical assistance with diagnoses on like histological specimens and so on, that has to be physically sent. But it is something that we are looking into how we can sustain that going forward outside of the initiative, because obviously it's not an infinite thing. It does have a time frame over which it's gonna occur and then end. But you know, we are looking to the government and the politicians, you know, to really help us to maintain that kind of arrangement. Right now, it's being done kind of on a charitable basis, if you will. And, you know, I don't know, but there may be some minimal cost to it going forward that we would need their help with, because it really does help us a lot. The only other thing I would say in the context of what Rebecca presented is that I am glad to see COVID has forced us to move forward with technologies. And so just as you and I think one of the other families alluded to that they were able to do a lot of their schooling online, I hope now that we would see infrastructure within our schools here that would be able to help us to facilitate continued integration of our cancer patients into schools still through the availability of being able to access their education online. Because as it is right now, we don't have the luxury of having in-hospital teachers and that kind of thing, although some teachers do really try to help out with some of the students, but not in all cases. And it would be great if even, you know, while you're receiving care, you can log on and join your classmates.
Speaking further to your point, it's really, I've had a really interesting, a bunch of interesting experiences during the pandemic, particularly for those patients that have been diagnosed as at the start or during the pandemic. They, because of our advances in technology during the pandemic and our use of increased technology in different ways, I've had a lot of different patients say to me that they actually feel less isolated because more people are kind of conforming to the isolation aspects that a lot of cancer patients and families experience. So that's been really interesting to hear. I also think that especially with the patient population that I work with, a lot of them do go to bone marrow transplant, and that can be an extremely isolating experience, especially when you're admitted to the hospital for months on months, it could be. And I think it's now that a lot of things have gone virtually, a lot of patients and families can be connected to virtual support groups or virtual meetups with other kids or young adults going through similar experiences. So I actually think that there's been more of that. And just adding on in terms of medically speaking, we've done a lot of telehealth at MSK. In the height of the pandemic, we were seeing all off-treatment patients through telehealth, which was truly incredible to see the advances in technology and how quickly that turnaround was, and we were able to make that happen. But I definitely hear the value in having those networks to communicate and share medical information, pathology reports, things like that, to just collaborate in terms of having as many experts as we can as possible.
Yeah, and we're seeing how technology is changing, and that goes along to not only from diagnosis to dealing and management of the treatment and the system, but also just pure treatment. So Dr. Maxwell, I had some questions. One question that was directed that asked about kind of treatment and whether there were kind of complementary or lifestyle changes that can augment the medical treatment to help support patients.
Right. So that's actually a great question. And there's been quite a bit of research in that area because, people have tried to figure out, is there a particular diet that works better? Are there particular dietary restrictions that should be imposed when patients are undergoing therapy, particularly when their immune system is pretty low, i.e. they're neutropenic? And I think the summation of most of those studies is that the things that are advisable when you don't have cancer are very similar to the things that are advisable when you are undergoing treatment for cancer. So, we really try to emphasize just balance, physical activity as much as is reasonable with whatever limitations may be imposed by your therapy and by the fact that you may need to maintain certain isolation for a certain period of time, for example, with bone marrow transplant. But within the limitations of that, we found that sort of embracing as much of a normal diet and high level of physical activity as possible really contributes in the sense that it's good for the mind, and a healthy mind is always a contributor to a healthy body. But in terms of specific therapies or specific complementary or alternative therapies, there are really none that have necessarily held up. So I would say things that contribute to your general health are also the same things that should be maintained during therapy.
That's excellent. And I think in matching that, I think the theme has come across in terms of treatment. Bone marrow transplant comes up quite a great deal because it can be a pivotal and curative phase of the treatment. And so can you speak to, the challenges of bone marrow transplant? I think we talked about the isolation, but just the idea of having diversity in the donor pool, the idea of making sure that people have access to facilities that do these specialized procedures.
All right. So first of all, the access to facilities that perform transplants is an issue. It's not so much an issue that we think about here in New York City because we have, so many large academic medical centers sort of in a concentrated area, but certainly in other areas across the US and definitely in other countries, this may not be something that's available. And because transplant is such an intensive process, it really requires a full team effort. These patients, what we're essentially doing is we're ablating or getting rid of their entire immune system and replacing it with the immune system, of another person. And so there are unique complications that come along with that. The isolation is one of those. I mean, for the first a month to 2 months, you can basically be expected to be on pretty severe isolation precautions, though now in the age of COVID, we're all sort of with heightened awareness of what isolation means, and all these terms such as quarantine have become a little bit more commonplace, but for patients, that can really be a major barrier in terms of the psychosocial impact of that. And then even after leaving the hospital, after that period of time, and in one of the families spoke to this, really just maintaining as clean of an environment as possible. And that may mean you may not be able to have, you know, friends and family over in the way that you would normally have. So that definitely does have a big impact. And then just in terms of survivorship going forward, so there are as many complications as there are to therapy and the types of treatment that we give, it's even more intensified in transplant. And so because you're getting higher doses of these agents, you're exposed to more toxic agents. You can have complications down the road. One of the families mentioned graft versus host disease, which is basically what happens because you're now taking on the immune system of another person. That immune system, which is foreign to you, has the capacity to sort of attack the cells of your own body. And so that can cause issues, both in the short and the long term, requiring sometimes being on immunosuppression for quite a long period of time. So those are some of the major issues. Mostly
interrupt the diversity of the donor pool, I think.
Oh, the diversity of the donor pool, yes.
To our conversation.
So that's a really great point, because especially as people of Caribbean descent, what we know about the donor pool, particularly the donor pool in the US, is that it's primarily a non-Hispanic white donor pool. And because of that, there tend to be fewer donor matches for people of color. And so it's really one effort that is really important moving forward, because the more people you have who are registered, who are of diverse backgrounds, the more likely it is that you're going to be able to find a match for a person of diverse background. And so there's a national organization here in the US called Be the Match. Really, it's so easy to become registered as a donor. It really is just a cheek swab, and then they have your information. And then, of course, if you're the match for someone, then they'll talk to you more about what that process entails. But similar issues come up even in terms of being a blood donor or a blood product donor, because again, we know that those specific antigens need to be matched, and the pool of donors that we currently have doesn't necessarily always match the pool of people that need those products, need that support.
Okay. And so I just wanted to thank everybody for participating in this conversation. Our presentations were excellent and really provided a diverse pool of insights and perspectives to cancer care for pediatric patients. In 15 to 30 seconds, can you give your final points and what you want to take home message? Dr. Brown?
Yeah, so I think, there obviously is still room for improvement in terms of the cancer care that we're able to deliver, but I don't think it's something that is impossible for us to achieve. We just need, more focused attention to cancer care delivery in Barbados. We need the support, because we do have personnel resources, as well as certain infrastructural resources that we can pull on to treat most cancers, even though some we may not be able to handle. So specifically things like neuroblastoma sometimes can be a problem, or children with relapsed leukemias and so on. But when you get an early diagnosis in a child, the likelihood that you can cure them is actually quite good, even in our setting. We just need to have the support. And as you can see, I mean, with very little, we were able to move from a survival rate of 30-something% to 60%. And with just a little bit more, I'm sure that we could get even higher, 70 to 80%, and that would be great.
That's excellent. Ms. Jacobs?
Yeah, I think a lot of us had touched on this, and it came up a lot in discussions. I want to emphasize the importance of collaboration and communication in all senses of the word, especially since, you know, a cancer diagnosis can be extremely devastating and nerve-wracking and shocking to families and patients. And I think that, you know, all of members of the interdisciplinary team, whether there's 2 people, whether there's 100 people, we're really all trying to be here and help support patients and families. So in any way that we can do that to increase collaboration between staff members and families and community resources, I think is just going to help in terms of just collaborative care and address psychosocial needs, because they're all related, and medical and psychosocial needs go hand in hand.
I agree. Dr. Maxwell?
So for me, I would put in a plug for enrolling in clinical trials. I think it has been the engine that has driven us to where we are today. And it is what's going to help us keep moving forward in terms of developing new therapies, and also in terms of understanding how we can reduce the toxicities of our current therapies, because as we cure more children, we're going to have more survivors, and we have to figure out ways to reduce their risk of chronic complications and ways to care for them better. So that would be my plug. If you know anyone who knows anyone and they're a little bit wary of this clinical trial, I would encourage them to enroll.
And I strongly agree. As a member of our phase 1 clinical trials program at Hackensack, I promote enrollment in clinical trials when at all possible. We get so much information, and that's where all the new therapies come from. So thank you all. Thank you to the families that have participated and shared their stories. They provided such amazing insight. Dr. Paris, I will turn it over to you.
Actually, we'll turn it over to Janice Reed. Thank you very much, Dr. Proverbs-Singh. I'm sure everyone will agree that we had a great session, and that's great is not doing it any justice. I've been receiving a number of texts from various ones. So I know it's getting late, so without any further ado, I'd like to turn it over to Janice Reed, who is the president of the Barbados Nurses Association of America, to give the closing remarks. Janice?
Good afternoon, everyone. I must make a correction. I am the vice president of I am the vice president of the Barbados Nurses Association of America, Inc. And I am pleased to bring you remarks at the end of this afternoon's presentation. We are indeed fortunate to have 3 longstanding base organizations who collaborate annually to educate our community on specific cancers through the offering of the Deborah Brathwaite Annual Cancer Symposium, with this year's focus on pediatric cancers during the Childhood Awareness Month. First, I'd like to extend a thank you to Dr. Edward Alleyne, the Education Committee chair, for his welcome remarks and introductions. The Reverend Canon D. Stevens Fields for giving us the invocation this afternoon. To Heather Marsh, who's the president of BACA, for opening remarks, and thank you for the overview of the Deborah Brathwaite Annual Cancer Symposium and the role that the late Dr. Brathwaite played in the activities of BACA. Ms. Gail Brathwaite, sister of the late Deborah Brathwaite, for her continued support. The Honorable Mackie Holder, Consul General of Barbados, for his opening remarks and for emphasizing bridging the gap between Barbados and the diaspora. To Dr. Tracy Proverbs-Singh for moderating the session this afternoon, today's symposium. Your expertise was valued. You lend your expertise in summarizing the sessions and also to facilitating the question and answer session. To Dr. Maxwell, thank you for that excellent overview of pediatric cancers. highlighting the challenges, the achievements, and the opportunities for advancements. You really highlighted that as it's essential to have a tissue diagnosis in order to treat that patient. That is very, very vital. Without tissue diagnosis, we cannot treat. And you actually highlighted also to the treatment modalities that we use in treating patients in pediatric cancers: chemotherapy, radiation, surgery if needed. You also highlighted the outcomes, the treatment outcomes, and the survivorship. I know you just mentioned about clinical research. That is very, very valued, because we don't have research, we cannot get new treatments to treat our patients. And you also too highlighted the surveillance for the pediatric survivors. That's been very emphasized now, because a lot of our pediatric patients are living longer, and we find that they're also too having late side effects of treatment that challenge to meet, and also to the secondary cancers that are being found, and the fertility issues. So thank you so much for highlighting that information for us. Dr. Chantelle Browne-Farmer, Browne-Farmer, thank you again for the excellent presentation on the barriers of pediatric cancers in Barbados. Some of this information I was actually realized that we have so much here in the US, and in Barbados it's a lot of work to do in some of the challenges that you face. Challenges regarding the specialized, the limited specialized personnel. You have lack of radiation oncologists there, pediatric radiologists, hematologic pathologists. You have limited resources for even for transfusion of patients. Platelet transfusion, that is, you have limited resources for that. And I think there is a lot that we probably would need, that we're gonna need to do to kind of, to collaborate, to help to give some support for some of the challenges that that are faced back home in Barbados. To Rebecca Jacobs, thank you so much for giving us the overview of the psychosocial aspects of pediatric cancers at Memorial Sloan Kettering. You did give a good overview, excellent overview of your role and what you do in supporting the patients and their families. Especially with those students who are unable to go back to school, you highlighted the DOA teaching for continuing education for MSK kids, and your involvement in providing resources in terms of emotional need, financial need, and resources for not only the patients who are within the US, but those international patients as well. Dr. Paris, thank you for facilitating the panel discussion on the impact of pediatric cancers on patients and their families, and also for your overview of the hospice initiative in Barbados. Thank you to the families, Ms. Michelle Jordan, Gabrielle Codrington. Thank you for sharing. Gabrielle, I was impressed that you actually went into research your treatment options there. You you searched information in order to find out what was best for you before you followed through on your treatment. And you did highlight the positive feedback regarding your treatment at MSK. The Grisette family, thank you so much for sharing your advocacy and getting your treatment at St. Jude's and what impact that is, it has been for you, and the resources that you're being provided even back home in Barbados. The Matsu family, also to thank you for sharing the journey of your child going through this illness. Recognize that the family is very important in facilitating and carrying you through these journeys during cancer. Cancer affects not only the patient, but it affects the family as a whole. And it's very important that we have family support, because without the family, sometimes the outcomes are not, sometimes they can be barrier to positive outcome. So thank you so much for sharing that information with us, and the challenges that you face. To the Education Task Force members, thank you also for your hard work and collaboration in developing today's program. Special thanks to Linda Watson-Lord and Danielle Rouse for your assistance in enabling us to present our first virtual symposium via Zoom during the pandemic. As Heather mentioned, we usually have our symposium at Kingsbrook Jewish Center, but due to COVID, we've had to utilize our online system via Zoom. So thank you both for working behind the scenes to making this a productive evening. And to the attendees, those of you, all of you, some of you who are here in the US, Canada, Costa Rica, and in the Caribbean, thank you so much for your support, for participating in today's symposium, because without you, this would not be a success. We hope that you found the information helpful and it will be some benefit to you, and it has enhanced your knowledge and your awareness about pediatric cancers and some of the challenges that are faced through the patients and their families. We look forward to your attendance at our 2021 symposium, whether it be in person or again virtual, depending on what happens in the next year or so. But thank you so much, and we hope to see you then. And be safe and have a wonderful evening. Thank you.